Well, good morning. My name is Dr. Alan Lumsden. I'm the medical director here at the Houston Methodist DeBakey Heart and Vascular Center, the chairman of CV Surgery and the president of ISCVS. I'm joined here with Sammedh Jain. He works for Storts and he's a clinical specialist who's on site. He's going to be able to help me with some of the information that I don't really know about the technologies here. The way we're going to do this is, first of all, we will introduce you to some of the technologies. This is called the Visitor 1. This is a robot that we're going to feature. On the left here is something that we've built, the folks in this studio have created. We call it a studio in a box. The idea is that if we want to bring in ground round speakers, right now we're completely embargoed here from doing this. This is a fully self-contained studio that we can ship out and link people like Kim Hodgson, who's the president of SVS, who I think is watching this. We can link him into the studio without him having to actually be here. In front of me, we'll talk a little bit later, is Intouch TV. This is a way of converting any office that's got a smart TV just by plugging that in and putting a camera on it, and then we can talk to patients. This one actually is from a remote clinic we run in Cincinnati and got kind of shipped down here overnight. Sammedh, do you want to tell them what you're looking at?
Yeah, so I'm on my laptop. Any Windows laptop or an iPhone or an iPad can access these devices.
So when we come to the demonstration part of this, we're actually going to have Sam, that's his short name, run this robot basically from where he is. But first of all, I'm going to kind of give you I think it was the use case. So how we're going to present this morning is I'm going to talk a little bit about clinical support. Our life has drastically changed really in the past 2 to 3 weeks here. So we're going to talk about, for those people who are interested in case support, particularly for devices. We'll demonstrate a little bit about open surgery. That particularly has relevance, we believe, for resident education and increasing resident autonomy. We're going to talk about a little bit, because there's a lot being written about this at the moment, clinical care, the office environment, increasingly in our ICU. And then we'll talk about medical education and how symposia can be run virtually, how we have some experience even in trying to run hands-on stations with remote proctor support. And then we'll touch a little bit upon remote monitoring, how we've used it. I put in brackets, looking to the future. We're very interested in remote-controlled interventions or remote-controlled robotic interventions, but I don't really have time to talk about this today. That's in the future. We are very much dealing with the here and the now at the moment, and we'll talk about some of the things that we've learned and how it can help you. So we've already introduced you. As you look at the screen, these are the different kind of robots that you see around here. The one to your right with the extension arm is called the Vantage system. That's what we use for open surgery, because you really need to have that extra boom above the patient so you can see straight down into it. The Intouch TV, what you're seeing here is that TV is a smart TV. It's got one of these sticks. Think of it like Amazon Fire, but this is for Hipaa Compliant patient interactions with a TV on top of it. That's the hardware that we utilize. I don't want to make this sound like a commercial for Storts. It is not, but those are the vendors that we interact with primarily. And so I really want to use that to demonstrate what these capabilities are. There are probably companies beyond Storts who have at least some of this capability. When you look at the icons down below, the Zoom, WebEx, Microsoft Teams, these really are the platforms that can be used for running a remote symposia. We have some experience with some of them. But right now we're using Zoom fairly extensively. I used that to run a symposium here recently, so I can certainly give you first-hand endorsement in the practicality and the robustness of it. I've never had an experience with it going down. However, I just don't have experience as much with WebEx or Microsoft Teams. Okay, so the case for remote support of complex cases. Bottom line is this technology is not new. It's existed for some time, but you know, getting traction in these new ideas is pretty tough. And one of the reasons it's not happened is lack of enthusiasm from the physicians. Why bother me with something when my life is really pretty good? Reps come in and support my cases. Why do I want to change? Well, all of a sudden it's changed. There's also been resistance from the reps. They like being in the room with the customers. What I've heard over and over again is, well, if I don't go in and support that case, my competitors are going to say, look, they're not even coming in, they're just going to do it remotely. We'll come in and support your case. So there's been a lot of different forces which are working in the marketplace which have really held this back. I think we're also culpable, and people who've been interested in it, we really haven't optimized some of these support platforms. And to date, there's been no real pending need case to make this happen. Well, life has drastically changed. And so if I look at the way that hospitals, and we have gone through this really in the last 2 to 3 weeks, and I'm sure many of the people out there see it from both the hospital side and also the vendor side. And so what we're being asked to do is to look and see, is the rep critical for the conduct of this case? Bottom line is we want everybody out of the institution who does not absolutely need to be there. And so you can think of a rep being critical in 2 ways. One, it could be the case. For us, fenestrated grafts, for example, complex endografts, TAVR is another example that's often been pretty heavily rep dependent. But the rep also thinks about it from a customer standpoint. There are some very experienced customers, they may not need the support. But there may be a completely different situation where someone has relatively little experience and that they really feel like, even though the case is not that complex, that they need to be involved in that case. And so the key basically is removal of non-critical personnel from the healthcare organization. That's what's really important. We have already shut down HMH's Houston Methodist. No access for sales, no access for product demos, and no, basically we're not even contemplating bringing on new devices at this particular point in time. So as I go through this, there's also a way that you can text in questions. And so you need to text questions to DeBakey. So you text DeBakey, D-E-B-A-K-E-Y, to 37607. So DeBakey, text DeBakey to 37607, and you can text questions. We will see these questions and we will kind of triage them as we go through this, and we'll handle them, try to bundle some of the questions together if there are questions which look the same, and we'll try and deal with as many of those as we can during this project and during this broadcast. So I encourage you to actually send in questions. Okay, so that's kind of the background business case from the hospital side and also from the medical device industry side, or why this is important. So what are we going to do? We're just going to stick these things out and say, off you go? No, it's not going to work like that. And so here's where we have kind of gotten to this, is we've started off by, we were interested in remote support from a variety of different situations. We started off by testing this in the training environment. And so this is Ali Irshad, basically he's now attending up in the Northeast. And what he's doing is, when he was a fellow, we would do device training with a simulator. Okay, why do we need remote support? We don't need remote support, but what we're doing is testing how this works. And so what happens is you can connect the simulator into this device. There's a whole series of inputs here that let you send that signal to a remote proctor. Denise is sitting there. She was told, keep your mouth shut, don't say anything, because we have a remote proctor who's actually going to be the one who's going to do the proctoring. And so the signal is sent just like it would be sent from a fluoro system, in a hybrid room, in a cath lab. That signal is sent as plugged into the robot. The robot then transmits that signal to wherever, in this case, the proctor is actually going to be. And so the system basically sends it to the robot basically sends it remotely, and what the remote proctor sees is exactly what is on that screen, whether it's on a fluoro screen or in a hybrid room, or whether it's even echo or transesophageal. All of these things can be sent and transmitted remotely. So one of the reasons for doing this is that the ability to do this remotely depends upon a couple of different things. Some of them are technical. It depends upon the audio quality. It depends upon the video quality. And it also depends upon a communication strategy. Again, you always wonder where the pilots say, hey, okay, so I'm coming in to land at the tower, over. That means it's your turn to speak, so that everyone is kind of not speaking over one another. That is not a communication style that we are used to, but you can tend to have to get there.
And one thing I would like to add, Dr. Lumsden,
sure.
to your audio and video quality, network, capabilities of the network on both sides of the stream is always of utmost importance. That network quality is probably the biggest limiting factor of any streaming technology out there, right? So if your network's not great on both sides, both the sending and the receiving, you might have droppage in audio, droppage in sound and video, and you might have latency.
So how can you test that? I mean, is there a way that people who are watching this can know how to do this? For example, and we'll come back and talk about this when I talk about the studio in the box. Look, we know you can sit down. Again, when I was at the SVS last year, I took this computer I linked into this studio so we would do a broadcast. I looked terrible. That's obviously important. I mean, you just look terrible. I mean, the lights all washed out. The audio quality was terrible. We've all had that experience. And so what we were trying to do with this is control everything. When a reporter goes out into the field in Houston and they connect into their station, the video is perfect and the sound quality is perfect because they control the uplink, okay? And so how can we do that? We bought 5G hotspots that we send with this so that we can somewhat control that. Is 5G, does it solve all the problems?
So not necessarily, you don't need 5G, but typically, for example, the hospital network, right? We have our guest network and we have our secured access network.
You mean the hospital network here?
The hospital network
so we have two different networks. One for everyday, the guests, and the other one which is, I guess, more secure.
More secure for Methodist devices and for Methodist personnel. So for example, if we before we had access to the secure network, we would put it on the guest network and we were having issues with latency due to droppage. It would still work, but it would also depend on the hours of the day. So for example, all the customers and personnel in the hospital is using the network most at the middle of the day at lunchtime. Everyone's on their phones, and so that takes up all the bandwidth. So if this robot is on guest network and we're trying to do a remote case, we're going to have issues.
So again, educate me here. I'm learning as we go through this. Can IT allocate bandwidth for you? Is there a way of protecting?
So they can, but the way we do it is just get access to the secure network.
Okay.
With the access
That's
to the
not a
secure
problem.
network, it's not a problem. IT in such a large hospital such as this, they have it worked out together. So.
Okay, thanks. So again, it comes down to who needs to be trained. I always say that what a rep is paid for is reading the room, understanding in different labs, what the boundaries are, who he or she needs to be able to communicate with, and how that communication takes place. And so now one of the challenges you're going to find is that typically a rep may run around and whisper to the scrub nurse, this is how you prep this particular device. Well, the interventionalist or the surgeon doesn't hear that communication. One of the things that changes is when you start using a platform like this, all communication is coming through this. So you kind of need to minimize that, and you need to understand exactly how that communication is actually going to take place. All right.
So we had a couple questions about the devices being Hipaa compliant. Yes, all the Intouch devices and the Visitor One technology is all Hipaa compliant, and that is probably the big point of all of this. If you're transmitting patient information or looking at a remote case or a remote clinic, you are essentially displaying sensitive information, right? So you need to make sure it's Hipaa compliant. So
that's a great question. In all honesty, that's how we got involved in this to start with. Can you remember the name of the guy who started Intouch?
I cannot recall.
Okay. So when you find that. So Intouch is an interesting company. The founder actually was one of the founders of Intuitive Surgical. He really wanted to make robots, and he went off and made remote viewing robots. But then they figured out that they needed this network with which you could communicate this, and that's where Intouch comes from. They actually build this network across the world, I guess.
And another question we got was the firewall. Yes, so it really depends on your hospital's IT network. So each department has their own firewall restrictions, and we've encountered that there's some features of some devices that require the network that are blocked, but we can use the rest of the features in that device. So again,
back to deal with some of these solutions. A lot of questions that are coming in. Let me see which ones I can deal with. Is that how in this work? Because one of the criticisms we always hear is, well, you guys got more money than sense. You can afford to buy all of this stuff. Okay, no, we got a lot of sense. So what we think of this, the way I've been trying to think this through is because what I've learned is my staff in the OR do not want to set this thing up. Your reps do not want to set this up. And so how are we going to do this? And the biggest problem you're going to have is dealing with IT. And so what you really need is somebody on site who can deal with IT. And this is why I've been pushing Storrs and say, if you're going to make this, if you're going to generalize this, it's going to have to be a model by which, somebody from Gore basically says, hey Sam, you know, we're going to do this case and we're going to do it out in Albuquerque or something like that on Tuesday morning, 9 o'clock. You guys have people out there, have this thing up and running and train my people before they use it. Obviously, they're going to have to charge for that. I don't think they've figured out what the cost of that is going to be, but I don't think you can do this with your reps. I just don't think that that's going to work. Like, that's my humble opinion. You have no opinion?
No,
that's good.
No opinion on that.
Yeah, all right. So I'm kind of showing you in screen left, and we're going to show you this in a lot more detail as we go through this. That's the input. On top of this system are 2 cameras, okay? And these cameras are near and far cameras. We'll show you the quality of the optics of these machines are unbelievable. On the right is what in this case, the Proctor, simply on the simulators. And again, we think of this as a great training model to get your sales force, you know, up to speed. They can download this. Unfortunately, my main criticism of Sammedh is that it doesn't work on, you know, this nice little Apple that's sitting here. But it does work on a PC, and so you got to download it on a PC, and you'll control that interface, and we'll show you really how to do that in a minute. And so that's really the view that the Proctor is actually going to see, and we'll show you this in a lot more detail because it's important. And so what we're going to do now is, this is a video. It's going to look a little weird because it was shot where I'm sitting some time ago. This is how you log on. So you log on to the Intouch network. You have a username and a password, much like you're signing on to your medical records. So I'm going to let this run. I may speak over it, but it gives you the idea of how this actually works. Should have volume on it. So basically what's going on at this point is that
number one, that I'd be
it's
given
logging
access,
on
and number
to the
two,
storage network,
which of the remote communication
and when it
platforms
does that,
they're going to give me access to. Some of these are robots, some of them what's called Intouch TV, related to the camera on a flat panel, for example. There's a variety of different methods of inputting the information, and we're going to show you what we do. So here you can see there's a whole bunch of different things that I'm given access to. Some of these are actually from the company alone, and some of these are systems that are actually here, you know, at Methodist Hospital. So I'm going to log on. This is the one I know is in our hybrid operating room, and I'm going to log on to that. So again, through this network, I am now logging on to what is called the Visitor 1, which is in our hybrid room. This is the room that I operated in earlier today, and essentially, this is what the interface looks like. I'm viewing this room through that robot, and if you look at the interface, so for example, this picture of me is coming from the laptop camera. The picture up here is coming to me from the robot. So this is and how this thing actually works, and we'll show you in a little bit more detail the interface. So this is kind of what you would see. The position of this robot is based upon what needs to be done. So for example, if this is the scrub nurse's table and the rep is actually teaching them how to actually prep the device, then you got to be able to look in on that. You maybe have to look up the device, and you can see how accurate the movement of these cameras actually are as I'm slowly panning up and down the length of the device here. And of course, in the room, the nurse can actually talk to us directly. A minute ago, we had to help. This is the control system for the hybrid room. So imagine we needed to give somebody tips about even manipulating the images. And so you can see just how exquisite these cameras are to be able to look at these different drop-down menus. This, of course, is the Siemens Pheno, which we're using here. So bottom line is I can look around the room, we can look at anesthesia, we can talk to anesthesia. There's several things that we recommend that I should be wearing a headset if we're really going to be controlling this case. So you don't hear necessarily all the ambient noise, and we can mic up really the people who are relevant in that room. So I have a view of the flat panel screen, just to show you that, obviously this is rotated towards me. If we take a slave monitor, you can actually even use this. You can stick this right in front of these cameras, and you can see how close we can actually see. And you can see devices on this really pretty easily. So there's a primary system that we actually endorse. This will give you the best quality.
lots of questions coming in. Some of them we're going to answer as we kind of go through them. Like, is there a laser pointer built into it? There's not a laser pointer, but we'll show you what the pointer is that's built into it. And you were going to point something out for me to answer? Okay, Yulin Wang is the founder. Yeah, Yulin Wang was the guy who was the founder of Intouch Health. Very nice guy. I actually met him once. Anyway, so let me kind of move on forward. This is Rich Rader. He is our rep with Gore. I've known for many years. And so essentially what we've been doing is training them. Really, we've probably been training them for the past 12 months. But every training and everybody wanting to be in the room, and so all that training kind of went out the window. And so we had to very rapidly retrain them. It doesn't take long. I mean, it probably, you know, if you take a smart person, they can probably learn this in 30 minutes. And so Rich is in this situation outside the operating room. The easiest thing to do is put on a pair of headsets, so there's no interference, and he can hear us pretty well. And we're implanting basically a thoracic aortic stent graft here. Again, I would not recommend this to be doing this in an emergency situation if you've never done it before. I fundamentally believe they need to put the time and effort and energy, which is not long. You learn this easily, you know, in a couple of hours. He's got to learn it before you actually need it. And so here's what we see on the other end of this. And so now I can see I'm looking up to my right. That would be here. I'm looking at Rich. That camera is very specifically positioned. So one of the things we've learned is you got to learn where to position these, and that's going to be case specific. And so you almost have to choreograph the entire procedure. What does the rep need to see? And so that's positioned there, so he can pivot that camera down and look to his left, and he can see the device. He can check the expiration dates, and he can help the nurse prep the device. He can see my hands, and he's getting a direct fluoro feed. Now, we've also set this up because, again, what I've said is that each of these setups is going to be specific for individual procedures, and you really need to go through that before you need it. Thoracic endograft needs to see fluoro, it needs to be able to see the field, needs to see the hands. Audio volume needs to be adequate and clear. He needs to be able to communicate with the scrub tech and be able to communicate with the lead interventionalist. So that's, again, how we set this up, and we set it up in the same room, same way every time. At least we try to do that. Don't always quite work like that. And the reason I say primary screen and secondary monitor, so if there was a problem, for example, with the fluoro feed, then we can simply rotate that secondary monitor, and we'll show you what that looks like. Really, that's all you really need. You know, if you had a problem, for example, sending the fluoro signal, which we've not had, we kind of have a backup secondary monitor in front of the robot that you can just rotate to and actually look at it. So that's the way this is set up. And here's kind of putting in, this is a dissection, we're putting a stent graft basically in here, and you can hear us talking backwards and forwards.
Yes. Huh? 20 centimeter long device, yeah.
Yeah, okay. All right,
That's okay, you gotta squeeze that, out of that device.
So then ask them to rotate down and to actually look at the scrub nurse's table and prep it. So this is looking at it from the other side. Imagine we're underneath the screen where the fluoro is. You can that machine pivots. And I'm going to show you that. We've put that in here. You can see that is all being controlled, in this case, by the rep. Rich's hands basically on the left. Basically, he's driving this and he's rotating it around and he's talking to me all at the same time. Whoever is on the remote interface controls the zoom, the pan, and you can see this thing almost goes not quite 360 degrees. How many degrees?
About 330. The only thing stopping it is the pole holding it.
Okay, so we're getting inundated with questions. Let me try and knock out some of these before we kind of lose. Okay, yeah, they keep magnifying it up for me because they know I'm getting old and my vision's not that good. And I can read it, believe it or not. Comment was, I saw one of these storage robots in use at a conference and loved it. Seemed super easy to set up. How long does your team need to set up for a TAVR case, for example? Depends what you mean. You mean pull this in at the time the TAVR is being set up? Well, it probably takes.
I think that's what they mean. Yeah, about 15 minutes.
Yeah, it probably
not
takes
too long.
15
Especially in an
minutes.
integrated room, you already have the connections on the booms, and you just, as long as you have the cables to make those connections from the robot to the boom, it's
How
pretty
much
easy.
does a system like this cost?
Now, I would defer that question to our
I'll
sales
take
engineer.
that on. This thing
Okay.
costs. I mean, you can't then hold me to the cost because I really don't work for the company. They're about ballpark 70 grand.
Yeah.
The ones with the big booms that come over are a little bit more expensive. But think of this as, so for example, I made a mistake in going to our hospital and saying, we really need to get more of these. Well, they were in the mindset of being in a clinic and seeing a patient. And they went, oh, we can't afford to spend $75,000 in every doctor's office. Well, that's not what this is for, and that's not what we're talking about today. This is for procedure support, okay? This could be for the doctor's office. Clearly, we can't afford to do that in every doctor's office, but you have access, whether you use the Intouch TV,
or the Viewpoint,
whether you use what's called the ViewPad, which is essentially an iPad. It all connects through that same Hipaa compliant network. What you see in the interface is basically exactly the same, but you can't control it the way you can control this. So nobody's advocating using this thing for simply seeing patients in the office. But I'll show you examples where we have done that, because it's battery powered. You just walk down the corridor with this thing and it will keep sending it. And so we did this a couple of weeks ago. One of my partners is up in the Woodlands. Woodlands is 45 miles from here. And so what we were doing there, instead of sending the patient down for me to see, we did it with Thomas Lowe. Thomas had the patient in the office. They have one of these. They just walk from room to room. I talked to the patient. I met the patient. First time I will see the patient is when he comes down to be operated on. All the follow-up will be done with Thomas. So you don't just have to stick it in an operating room. You can put this basically anywhere you want. But nobody's advocating buying something like this purely for an office-based practice. There are much cheaper and integrated in your medical record methods of doing this. Okay, and life codes now. Okay, we got that. That's a comment. How can my hospital get a visitor one from Storch? I guess you call
Yes.
Storch.
So each area has their own designated sales engineer or sales rep. So for our area in the Gulf Coast region, it's Naveen Yenugu. So I would reach out to him.
Okay, next question is, are you able to use your iPhone and iPad to control the Visitor One robot? Short answer is?
Yes, you are.
But? There's a but.
There's a but. So you can only use see one video feed at a time, as opposed to the computer, which I don't know if you were able to show that. But on
your iPad you can get two, is that not right?
Mm-hmm. Well, you can swap through the different feeds, but it's only one viewing at a time.
Okay, so what we showed you coming from the operating room is that you can have two synchronous video feeds coming up on your laptop. So again, for example, if we're doing a stent graft, you have a feed coming in from what the interventionalist is doing and the fluoro feed coming in directly. You can choose to fill the entire screen with one of them, so if you really want to mag up on the fluoro, you can do that. That functionality you lose when you go to the iPad and the iPhone. You can only get one at a time, but you can still control this. So I can log on right now into Storch in LA and drive their robots off their iPhone, and maybe that's something you should offer. That's one way to convince people how easy.
Now, one thing, what the iPhone and iPad's functionality to use the app is for is really just to communicate back and forth, seeing the very basics of what you need. So the Windows computer, using that as an interface to log into the robot, is more to see the details. So if you want to see your live fluoro, being able to see the finer details in that fluoro image is what that's for.
All right, question. My hospital IT team is pretty gun shy about new technology. Was the Methodist IT team amenable to get this robot in the door? Yeah, because it's Hipaa compliant. So they were fine with it. Our IT is also gun shy about bringing in new technology, but I can tell you, the speed at which we're doing this right now is dramatically accelerated. So I'm doing clinic this afternoon. Half my clinic will be done virtually. We've gone from resistance to embracement in this new technology. Actually, I got this information last night specifically for this. We now have 600 physicians who are all signed up to do telemedicine. That's integrated into Epic, for those of you who are on Epic. We will do 500 visits a day, and it is increasing exponentially. And so we've got whole areas that are converted over now to training our physicians, how to do it. So just like industry, we want to keep our business going, albeit trying to do it as safely as we possibly can. Just yesterday, HHS issued a relaxation notice for Hipaa compliance that is detailed in SVS Connect. Thank you very much for sending that in. Okay. Can I hook into this, into my Storch operating room? Aha.
Yes.
Okay. So let's hold that because we're going to demonstrate that. Okay.
Mm-hmm.
All right. I think you got most of that stuff done. Okay. Let's kind of keep going for a minute. Okay, so let me give you an example. This was, I'm going to screw up the name. This was a clinical trial. It was a redo percutaneous mitral valve. It's called a reversed lampoon. Whoever makes up a name like that for a clinical trial. Okay, that was going to happen here Friday. Okay, this is the first one that we'd done. That proctor is up in Emory. He called the night before and said, I'm really sorry guys, I can't get down there. I'm not allowed to fly. And so this patient was already in-house. The patient was going to get cancelled because we couldn't do it because it's part of a clinical trial. And again, power of the clinical trial. And so within less than 12 hours, most of this went from 1:30 in the morning, kind of all through to the case. First of all, the case was going to be second case. Then, of course, it gets moved up. And so this all had to be done for 7:30 the next morning. This was set up in this entire trial. So I'm going to, if you let the audio in this play, because Mike is talking to this guy up at Emory.
Yeah, it's a nice split. Look at that.
No, it's really not. As a surgeon, it just amazes me that you split these things and you don't go into immediately heart failure. Now, if you let this...
So, again, here's the situation. We salvage this. Patient's happy. Again, the OR team, the OR team had been incredibly resistant to actually using it. I've been pushing them to try and get their TAVR reps up and running on this. Well, I can tell you, everybody's now convinced. This was an Edwards study. Edwards now, probably some people watching this. This is how it was pulled off. Now, the good news was that the proctor at Emory had previous experience in using this interface. So that really greased the wheels a little bit in terms basically of making this work. As part of the ascending stent graft trial with Gore, that guy who's there, Mike Reardon, is the national PI on that. There was approval from the FDA to use remote support for that trial because type A dissection, you just can't get experts here in time. So it's beginning to be looked at. It's really interesting because I have written abstracts, publications. I managed to get my publication rejected by the journal that I'm the editor of because nobody sees the value in any of this stuff, and now all of a sudden this is kind of completely flipped. So that really was incredibly valuable to pull that case off. This is kind of from the other side. So what was being sent to that patient was the 3D echo, and we were sending the fluoro all at the same time, and of course he could communicate. Now let me throw you another example. This is something I went up to teach a course up at Boston Scientific, and it was about using angiojet for treatment of DVT. And everybody goes, well, we want to come down and watch you do a case. So, well, the problem is it doesn't really work like that. Patient comes in tonight, we do them first thing in the morning. Patient comes in this morning, do them this afternoon. But here's what you can do, okay? And I think this is grossly underutilized by companies, and that is that we have the ability to, sorry, I'm going to go back one, have the ability to notify you of a case which comes in tonight. So, hey, let's say we're going to do this angiojet or whatever the device is you utilize tomorrow morning at 10 o'clock. And we push that out to the company. The company can basically say, hey, this case is going live from Houston Methodist. We can take the first 20. It's kind of some debate whether it's 20 or 30 people you can log on to this at the same time. And the first 20 people can watch the case. They can talk to us. They can send questions in just like you're doing. And they can watch the case. They never have to travel. And so, again, I think that the opportunity to expand this capability for letting people see cases and to run clinical trials or support of clinical trials is absolutely immense. Okay, another question is, how do your fellows and residents feel about this? Nurses? Well, nurses are not any different from the doctors. First of all, they don't like the idea because it's new technology and they push back on it. But I'd say our nurses now see the value of it. And the unfortunate thing about this COVID experience is that this has been forced upon us. This is not going to go back to normal. I don't think it's going to go back to normal until we hit the end of the year. And even then, I think these systems will now be so ingrained that business as usual is gone. I think it's going to be completely changed. Okay, here's a question I hadn't even contemplated. Seeing that this is about COVID, how do you clean the robot? Any concerns there? How do you clean it?
So on the Intouch website, there's instructions on what sort of chemicals you can use to clean the robot, and they're all there. The usual germicidal wipes that you can find in your OR should suffice.
So yeah, now, let me make sure. I'm not advocating you use this specifically for COVID patients, although, you know, clearly COVID patients are going to end up getting sick and end up needing procedures done. I'm advocating, we see the power of this is that we want to keep people out of our hospitals. We're shutting down the staff. Half this education team is now at home. We've split our offices now in the process of doing this into 2 teams, a home team. We kind of starting to think of this a little bit like hurricane planning, and we go through that on a regular basis. That you got in a hurricane, you have somebody who comes in here for 3 days, and then you have a recovery team. And we're almost starting to think about this now with staff basically across the spectrum of the different specialties in the hospital. Can you record pictures or videos to save for future cases or research?
Yes, you can.
Yes. Are you all concerned about patient consent for these type of cases, and how do you handle that? So we get consent from the patient. So for example, that trial patient, the patient was aware that the case is either going to be cancelled or they're going to be supported remotely. Again, you know, we don't get consent for a rep being in the room in the first place. I mean, that's not something that's on a consent form, and so we don't say the rep's not going to be there because we don't even talk about that in the first place. Is it easy to add remote users?
Easy to.
How many people can watch this?
About 20 to 30 people.
And if somebody signed up today, how long does it take you guys to kind of process them and give them an account and give them access?
I've seen the turnaround time being about 24 hours.
Okay. All right. So how do you use virtual presence robots in the integration system in the OR? That's kind of like the OR1 question, and we'll show you that in a minute. So how do you plan to use robots for COVID-19 care? We're not. So it's very interesting. We have been building our virtual ICU I can't say every, I just don't know the answer to that, but probably at least a couple of 100 beds here now, you know, have virtual capability. Most of our ICU beds now have virtual care capability. I can tell you that the pushback from the medical staff was huge. I can tell you that that is completely flipped. And so right now, you know, COVID patients on ECMO, COVID patients on ventilators are being viewed remotely. And so we don't need to use this. You could use this, it's certainly a solution for it, but we have the luxury of having most of these communication platforms now built into our ICUs and in many of the negative pressure rooms where these patients are primarily going to be being taken care of. Any remote interactions with patients, I'll get to that. Okay. So again, this is Brad. Brad was working with Boston Scientific at that time, and he's actually helped supporting these cases. So we've been pushing our reps to learn how to do this for some time. Okay, let me keep going. And so this kind of. So that's what Brad. This is just taking a shot over the shoulder, looking at the interface. You can see what we're doing. You can see video being streamed. Here's kind of the idea of having a cockpit. Okay, this is an office not far from here. You can actually make these pretty sophisticated. It doesn't need it to be this fancy, but we've used this, and I've been increasingly using it for seeing what residents are doing. You know, we're a private practice hospital. We got to be there. One of the challenges is making sure that nothing happens, and so we use this really just to keep an eye really on what's going on in the operating room. Now, one of the questions we got was, okay, I don't have this, but I got all this audiovisual equipment built into the operating room. And so what you're looking at, I'm going to let this, because this is going to run, and what it's going to show you is that this is my operating room. We have cameras built into the lights. A lot of physicians out there already have cameras built into the lights. So my recommendation for the physicians and for industry is take an inventory of the AV resources that are present in the hospitals that you're supporting. You may find they've got a lot more than, number one, you realize, and half the time than they realize. And so these things have been put in and not utilized. And so you can tap into, so we have an integrated storage room. I can see what's going on in that camera without even using this robot, and I can see that remotely. And so this is just going to show you, you know, that there are many other resources. We think of these as input devices, inputting the video into that. Headlights, and you can see, you can make it sterile because the sterile cover goes over the surface of it, but just give you an idea of the quality of the optics that exists, you know, on this robotic camera. And so what we've done
is on the screen on your right now, rather than fluoro. Again, there is a terminal by which you can plug in a variety of different inputs. You can put in TEE, you can put in ultrasound, you can put in images from this camera, for example. So if you're going to do open surgery, you may want to have a camera that's directly overhead. And the picture you're seeing on the right is actually now not coming from the robot. It's coming from this camera, connected to the robot and streamed out through this. So I'm talking to the people in the room. Alex, can you go ahead and zoom in on the camera on your right? And again, just the same kind of idea. You can get some idea of the quality of the optics and some idea. Okay, Alex, why don't you talk to me so I can hear you?
Yeah, sound check, 1, 2, 3.
Yeah, so it sounds good. So we don't even have microphones or anything on them at the moment. They're just standing in the room talking to me. You can actually make it a lot better than this. So go ahead and zoom out for me now, Alex. So I can't control that light cam, the zoom from the robot. Somebody in the room has to do this as opposed. Okay, so what you were looking at when I zoomed in on the camera to start with, that was me zooming in using the computer, the remote interface to zoom that camera in. Then we switched over to the view from the camera. You can't control that remotely. You have to control that basically with an interface which can be in the room or close to the room. Questions that are coming in about, what about billing? Are you guys handling that? Well, we're not billing for any of this stuff. We can bill for seeing somebody in an office. And so you don't get paid a lot. You get paid like $50 when you're doing that. But you know, at the end of the day, you know, I think one of the other things that's going to absolutely change in this is this legislation is dragged on forever. And what you're now going to find is I think it's going to be fast-tracked through Congress, and hopefully those things are all going to be changed. Another comment is my clinic uses one. I added my resident and got him hooked into a case in 35 minutes. It was awesome.
That's awesome.
Thank you very much.
Yeah.
How's your management team taking advantage of this? Well, our management team is completely swamped at the moment. I mean, they're not focusing on this. What the entire organization is focused on at the moment is bringing our physicians up to speed in telemedicine. We're training hundreds basically every day. And so that's so we can keep patients out of the clinics and get as many physicians out of the clinics as we can possibly do that. So that's where the focus is. That was number one. Number two, the second area of focus is really on the virtual ICU. Again, huge resistance now to, oh, this looks like a stroke of genius. Roberta Schwartz is the CEO here, and she was jamming this thing through with a lot of fighting going on at physician level. I can tell you, now looking pretty smart that we actually have these systems in place. And again, for COVID patients, the problem with the COVID patient at the moment is you're burning through all these personal protection devices. And so every time you go in and out of a room, and so if you can reduce the number of times a nurse is going into the room so they can see patients remotely and be comfortable in their ability with that's a huge deal. Outside OR, do you see this as an opportunity for rural facilities? Absolutely.
Yes.
That is one of the areas we have not exploited. We went and looked at an area that's doing this. It's Craig Walker's group in Lafayette. I've got remote setups in like 10 different hospitals. They came here actually to see how we were doing remote interventions with the Corindus robots. And we used this to broadcast the case from the cath lab. I'm talking to their manager and I said, hey, you want me to tell you how we're doing this? And he said, no, we know how to do this. Well, he was the first person I'd ever met. He said, we use this in emergency rooms, and that's how they cover. So absolutely, this can, again, I'm not endorsing this specifically, but that's the one that I've got experience with. How quickly were you able to learn the controls of the Visitor One and laptop software? Well, I guess it depends which company you work for. Some of these people will come up to speed faster than others. That's a joke. It's easy. It doesn't, to get the basics out of it will probably take 30 minutes to an hour. There are a few bells and whistles that you can learn above and beyond that. It probably takes about another hour. But you gotta do it. I mean, one of the problems you get is you train people and then they sit on it and then you wait 2 months. It's like going from scratch all over again. For remote case observation opportunities, do you recommend live cases or recorded cases? Why or why not? I don't think it matters. I personally, I don't mind doing live cases. I don't want to do high risk live cases. fundamentally think that well-edited, recorded cases are probably as good as any. Do we have problems with firewalls, video within the hospital? I don't, but that's because I got this guy, and that's why I recommend you really need somebody on site, and that's why I think looking at the bad word strikers and Storces of this world, they tend to have people on site who've worked with IT who can help get through these firewalls. That's all. Right. How are these devices used to interface with patients? We'll show you. Okay, so let me just keep going here for a minute. So again, this is now using an overhead camera. Okay, I'm watching the resident cutting down on an AV graft, and so it's a light cam. There are some people have room cams. Some people basically have direct fluoro feeds that you can show, and you can see this is an angiogram. We're looking at the angiogram directly, so I can see the early phase of the procedure where they're cutting down, and then I can see the angiogram when it's done. I'm going to run through a few examples. Now, one of the other things that you start to get fancy on this, we have started, I learned this from Rod White actually, when I went out and visited him in Long Beach. They use Quail digital headsets. And we bought this and we use this in the operating room. This allows you to connect the team. So anesthesia wears it, scrub nurse wears it, the two physicians, in my case surgeons wear it, the circulator wears it. So when they're out of the room and they're going off to get basically a 10 millimeter by 37 millimeter stent, and as soon as they're out of the room, I change my mind about what I want. I don't have to wait and then coming back. We can communicate. So it keeps the team together. Now the nice thing that we kind of discovered is they can link into this, so the remote rep can actually be talking to them, and it helps connect the team in the operating room. And so, because the audio is very important, it's not just being able to see, you got to be able to communicate well from an audio standpoint. All right, so other examples, you can actually connect in the fluoro, and so we can connect in the fluoro. If I'm watching somebody do vascular access, we can see basically the fluoro image comes live, and we can coach them remotely. And this can be done internationally. You can really kind of use this kind of thing, you know, anywhere. And if we've got time, I'll hook up that ultrasound over here. It plugs straight into the back of this machine, and then you can see the ultrasound remotely. Another simple example, I'm talking to the resident about doing CO2 angiogram. We got a direct view of this. This thing is the best thing since sliced bread for CO2. That's the Commander. We don't use the on-the-floor tanks at all anymore. And I can, again, see what he's doing, and I can actually see this. I'm not very versed with all the closure devices. People used to say, what closure device do you use, Dr. Lumsden? I say, well, I use a resident, and they can use whatever they want. And so, so even for coaching somebody like me, if the resident's not there to, in this case, use a Minx, you know, that's easy for it to be done remotely. A rep doesn't need to be sitting there for 4 hours for a case, and then basically for 5 minutes for me how to do this. And the other interesting thing is that we have all of the demo videos of how to prep these devices loaded up in our hybrid room. And so it's ludicrous that in order to refresh my memory of how to use a device, I'm supposed to run to the control room, search YouTube, and pull this thing up. We've downloaded all of these, and we put it comes up on the screen right in front of me. So that's a freebie. This is the other way we can do remote proctoring, and in this case it's an open aortic operation. I'm just sitting, you know, drinking a cup of coffee, and you can see
so the next thing
watching.
I do is stay on the front of the aorta and go down the aorta. Because as you start opening that peritoneum, the duodenum's going to displace further and further away.
And so this is the quality of the view, just up close and technicolor when you go back. And so, you know, what I can show you, that's the, I don't know if this shows, but that's the renal vein over the aorta. And so they're pretty far along in the operation. I'm not going to stand down and watch them sew on the graft, but during the exposure. I was asked if we've used this in the clinic, and again, so what happened to me was that I managed to go to Italy before this thing broke out, to go to a rugby game. The day I landed in Rome, there were 3 cases in the north of the country. 2 days later, when I left Rome, there was 200 cases, 250 cases actually. The day I got back here, the CDC declared Italy to be a level 2 country, and I got booted out of the hospital actually. Fortunately, everything's all well, but I had patients to see, and I was running a symposium, and so that kind of forced me to sit there and think about this a little bit about, you know, what are we going to do and how this is going to change. And so in this case, again, same visitor 1, you can use it in the operating room. This case is just trundled across to the exam rooms, and I interview
interviewed a patient. That's Edward, who's one of our residents, basically in the background, talking to the patient. Well, I'm talking to him directly, actually. It worked great. Feedback was good. This is one of my partners, Randy Wolf. Randy Wolf is an expert in it's the Wolf Mini Maze, an operation he developed for AFib. And so instead of getting ablation once, ablation twice, ablation 3 times, there is a minimally invasive surgical option that he kind of pioneered. But that's pretty specialized practice. And so we do these second opinion clinics, and that's where this came from, because he came from University of Cincinnati. A bunch of people refer to him. Essentially what happens with the Randy is the patient goes into the office, and Randy interviews the patient up there and sees the patient and can talk to them. So let's move on now to remote communication for education and patient care. Again, I mentioned the fact that I got booted from the hospital the day before we were running the DeBakey CV Symposium. And so this, I just called in a few of my friends who were around me at the moment and said, I got to figure out, how I'm going to, help chair this remotely. That's my house. You kind of wear a tie when you actually go on and kind of look professional. And so that allowed me to actually remote in and to run this. People talked about other applications for this, and so that's an interface from our virtual ICU. It's an interface of how we're doing telemedicine visits, but what has changed, as I've already mentioned, this has gone from resistance to engagement. Nobody was really that enthused about the virtual ICU. Now we're highly enthused by it. Nobody was real enthused about telemed visits. Now, as I say, we got 600 people on it. And so where this will affect you is that this massive increase in interest will drive investment into this. It'll make it better and better. All of that investment in telemedicine can be sprung over into case support. And so I think we're all going to benefit from the fact that, number one, the physician population is being completely flipped in terms of their approach to this. Number two, the acceptance from patients. So when we discharge a patient now, we tell them that we would like them to consider to be followed up remotely, and we'll set them up with a telemedicine visit to see me. And so we're priming, the pump is being primed, and I think people are going to be real interested in it. Back to our extra bedroom at home, that's kind of, again, you want to get the light on it properly. We've got an accessory iPad where it was handling the questions that were coming in. But this is what you saw on the other end. Interestingly, you can put these virtual screens behind you. So that's me sitting at home in front of that wall, but it makes it look like I'm in my operating room. So you can have some kind of fun with it. This was Zoom based, and it was very effective. We had a speaker who came in that night from NASA over at one of the other hotels. We just moved the whole thing over to the hotel so I could kind of introduce them and watch it and feel like you're kind of part of it. On the afternoon of that meeting, we had a whole bunch of hands-on sessions, and I was supposed to be manning what's called the Storch Collaborator. This is the very sophisticated system by you set up the case. You can bring in all the imaging, you can bring in the case carts, you can bring in the timeout. All of the stuff basically goes into that. And so since I couldn't be there with Sam, I just kind of came in remotely. Okay, so I've got Dr. Lowe. Dr. Lowe is at the Methodist in the Woodlands. And so Dr. Lowe says, we did our first telemedicine visit this morning with a complex PAD dialysis patient. I'd originally canceled or pushed my clinics, but started getting worried calls from referring physicians. And so the problem for us that he's highlighting is that what we're doing right now is going through patient case log and going elective, purely elective, push them out. They're going to have to wait. And then the emergencies, obviously, we're going to do under any circumstances. But there are a group of patients, particularly in the CV world. You got an aneurysm 7.5, 8 centimeters, or you have a patient with a high-grade aortic stenosis. The mortality rate from that is probably almost as high as COVID is. And so we're really trying to triage those patients and bring them in. So thanks, Thomas. I'm glad you did that. I get to embark upon this afternoon. Hopefully it goes as well as this broadcast is going. Okay. My department chair would immediately want to know how my time would be billable for something like this. Well, here's what I'd say to your department chair. You ain't going to be billing anything, for a long time. And we need to figure out how we keep this going. There will be a massive rebound on the backside of this. And we really still want to have first contact with patients. So I want, even if I was giving this away, right now there's a $50 copay, but right now, even if we were giving this away, we'd be doing it. As interventionists, we don't make our money, by doing medical care, in the clinic. And so it's highly important that we retain contact with these patients, that, you know, if a patient wants a consult for an aneurysm, I'm going to do it. You know, if it's a huge aneurysm, we're going to fix it. But if it's down in that, you know, 5 to 6 centimeter range, I'm probably going to persuade them to push it off, but I'm going to give them the follow-up. Is Methodist leading the way on this idea of remote consulting, etc.? Seems like you guys are ahead of the curve, even for bigger systems. Well done. Thank you. Thanks very much. Yeah, I mean, it's, I don't know, it seems to me like this has been obvious. This is coming for a while. On the medical device side of it, their huge costs are in the reps. Now, and so the first reaction from reps has always been, you're trying to put me out of a job. No, I'm really not trying to put you out of a job. I would like you to be more available. I'd like you to be able to cover more cases than you are at the moment. And that's what I think this does. So next question, from a healthcare professional's perspective, would you view a sales rep proposing this as a valuable opportunistic given the circumstances? I think this idea of people being opportunistic, it's gone. Life, as you and I have practiced it, is not going to go back to normal for the rest of this year. I think that, you know, I mean, my suggestion, if you're part of a big company, is they buy one of these things, or, you know, or they work with stores and say, we have a solution. I think right now, if you go to the hospital and go, hey, we want you to buy this, the hospital administration is swamped, you know, at the moment. And so the mind space, I think you need to go to them with a solution that is reasonable, and you'll get an audience. That would be my suggestion. Does this robot and other screens have good support if we run into an issues?
Yes,
I don't know. These
think
guys
so.
are a little shaky. No, I'm just joking. I mean, the support's been great. Go ahead. Yeah.
Right. So yeah, it's great. So whenever we do have issues, whether it be with the network or a video, audio issue, we're right there in the room to help support it and try and fix and improvise on the issue.
Yeah, but I mean, we're in a different situation. We guys have you guys here. What if you're out in the boonies somewhere and something goes wrong? How would you support it?
That's a great question, which we have not encountered yet.
So I mean, here's the question: is that, you know, it's great you buy a device. I've got a Nordic track. Okay, I had this thing for 3 months and it's not working, and I am damned if I can get anybody on the phone and I can't get it fixed. And so, you know, I don't want to be part basically of showing people this, and then because they're going to call me and then they're going to go, hey, we bought this thing and it's not working, and I can't get anybody from stores. Are you going to help?
Yes, of course. So
we'll give you his number. At the end of the case, we'll give you Sam's number.
Sure thing, sure thing.
So, you know, I can only talk from my experience. So we've not had any problem with it. I would hope, given the fact that I'm talking to you, that it would work. This is another example. Is my partner Eric Peden. He's not just seeing a patient. He was actually demonstrating into one of the conferences on how to do vein mapping, and we used it. So this is very flexible. We use it for symposia. We can trundle it over to see patients, and we use it in the operating room. And this is kind of using Zoom to actually transmit. One of the challenges, we've used WebEx to try and run conferences, and I have really been not impressed with it. And so we put Zoom through its paces, because the big problem is actually streaming video. And this was a patient who had a type 1 endoleak. We're actually using this. And so that's an example. Other ways you can get really sophisticated, we actually broadcast this, and this is on our YouTube channel. Same YouTube channels you're probably watching this through. If you're not on YouTube, look at the DeBakey CV Education YouTube channel. And we use this really to transmit across the world, actually to the Middle East. We were actually showing how to put in a Percival valve, which is a new sutureless valve by Dr. Ramchandani. So that is from this little system here sitting beside me. And so what this is a studio in a box, okay? Again, Mike Quinones Baldrich is coming out here next week to give grand rounds. He can't come. His institution won't let him, and we won't let him. And so we're going to ship this out. And the idea of this is a fully self-contained studio. That it controls the uplink. The little microphone sits in there. It's got its own built-in light, so you kind of don't look like Frankenstein like I looked when I was up at the SVS. And it will link directly into us. So we really want to. I think we really need to keep medical education going through this, and this is one of the reasons that we're kind of doing these things. Another use case is we do a lot of transcranial Doppler. That's where you measure flow inside the head, or we're doing it right now during some of the TAVR cases. Our expert is a guy called Zolk Garami, and he travels. He's internationally in demand, and so we can plug the TCD in here. He's doing this over in our office just to show you. but he's monitored my cases from Hungary. And so he sits and you can see on the screen on the right, the TCD signal. He sees a carotid endarterectomy or a stent, and he tells me when to shunt or not to shunt, basically from Hungary. And so this is kind of Zolt telling us what to do, and you can see his face is in the screen. So you end up talking to him. You kind of feel like he's in the room beside you, to be honest with you. And that's kind of what he sees. He sees to the left of that interface, he sees the procedure, and to the right you can see the Doppler signal that's coming in basically out of our patient. So we're going to start winding down this kind of lecture part of it. For those of you who need to drop off, I'm going to get Sam, shortly to demo some of these procedures. We're actually going to log on and show you this being utilized. Probably take 10 minutes if you want to stay with us. But let me kind of run through what I think of the applications. And the good news of people being interested in this is I'm sure you're going to think of other ideas. It can be used for preclinical device support. The one thing I've not put in here is we can take this up to our research lab. We have a hybrid room in our research lab. A lot of companies come here and do studies. You don't need to bring your entire engineering team in here. We can plug this in, we can remote. And when we were working with Hansen, the engineering team would set out in Mountain View and they would send one engineer in here. That's one of the areas of value. Clinical trial support, I gave you two examples, the Go Race ending trial and the Reverse Lampoon trial. That case would not have happened had we not been able to turn this on fairly rapidly. Device training, again, a lot of people send proctors out to teach residents on a simulator. That doesn't make any sense to me. That can be done with that proctor remotely as long as somebody can bring in the simulators. Remote viewing of urgent cases seems like it's ideal. You got a dissection, we're going to put a stent graft in, people want to see it. We can, at a moment's notice, we can turn it on anytime. You just need to figure out on industry side who they want, who their customer base is that would be interested in looking at it. Remote proctor, again, you've seen an example of a remote proctor. Personally, I'd like to see our entire group be proctors for the world. We really talk about setting up a proctoring center here, and obviously I think it's a win-win-win for everybody. It's good for us, we're not going to do it for nothing. It's good for the company because you save money on airline travel, particularly international airline travel. Proctors fly internationally and the case gets cancelled. It's a total waste of time. And so do I think that the first time you see the proctor, is the right time to do it? No, I don't. I actually think that what should be done is we think of this as people come here to be trained on these devices. We're going to train them on remote proctoring while they're here. So that's acceptable to when they go out there. We also think about this could be used for patient recruitment and screening. I mean, you can put us out, and around in a variety of different places where we can talk to patients that we're particularly interested in screening. Resident training, graduated responsibility, and remote monitoring, basically the other things that we've talked about. So that takes me out of it. I'll go back to, can you turn us over on to Sam? Yeah. So that completes the didactic. While Sam's coming up here, let me just deal with some of the questions. How do we get a list of devices and contacts of the ones shown?
So as soon as you register on Intouch and get your account or register through Storts and
yeah,
get
but
your account.
how do they, but a little more basic than that. Before they sign the check, basically, they're not going to remember what this is called, what that's called, is where would they go to see what a list of these different devices actually are?
Oh, so on the website itself, on the Intouch website, they have a list of all the different robots. Okay. And if you're going through Storts.
Intouch is the way. There's kind of a weird relationship between Storts and Intouch that I'm only now figuring out. Intouch builds these and controls that network. Storts really deal with people like me when we're installing them in cath labs and
yeah, so we're big on AV integration. So yeah. Our role is integrating this in the operating room, in the clinic, wherever it needs to be.
Okay. Does the robot communicate via Wi-Fi? You want to put his screen up so they can see his screen? That we're going to do?
Yes, so it does do Wi-Fi and Cat5. So obviously we talked about guest Wi-Fi networks being the lowest quality, but then if you get on the secure Wi-Fi network, that's much better quality. But then if you use the hardline Ethernet connection, that I recommend is the best quality. So if you have access to that, and once again, it all goes through IT. IT needs to green light for you to get on the secure Wi-Fi and on the to have Ethernet access, then yes, you can do both.
Okay, back to the support question. Is there a 1-800 number that they can call at 3 a.m. in the morning and
yes,
get one of you guys out of bed?
Let me pull that up right now.
Oh, we're going to give it to you. I was going to give you Sam's cell phone number.
No, please.
All right, and
All right, so that 1-800 number is 1-800-421-0837. So we have 24/7 remote support.
Say it again.
That is 1-800-421-0837. That is 24/7 Carl Stores customer and technical support.
I just use Sam. Can we get these slides of a recording of this webinar? Okay, yeah. So I'm in the DeBakey CV studios. This is a studio that exists in the Heart and Vascular Center here. I would really encourage you to subscribe to some of our. Let me give them the little card here. It tells you what they are. So if you subscribe on the YouTube channel, okay, it's DeBakey CV Education. Look at the YouTube channel. We're also up on SmugMug. We've got the usual stuff, Twitter and all that kind of stuff. But the YouTube channel is where we will post this. You know, when we come down from this, it'll be posted immediately. They will edit it a little bit and then repost it again tomorrow morning. And so we use the studio to produce, we would like to think we're producing high quality education. Right now we're going to start turning this over a lot about coronavirus and what's going on. I just saw Dr. McGilvery in the control room here. He's the chief of cardiac surgery here in our department. And you know, now we're dealing with ECMO. And so we're going to deal with PAPR training. We're probably going to shoot that this afternoon. We'll post that. Now we're going to start moving into the next phase of how do we start training people around things like, you know, ECMO, turning these patients, and how is there a possibility of doing some of this remotely. So stay tuned to this. We're completely tuned into what's going on. We're living this, much like you are at the moment. And so what we're talking about a week from now is probably very different from what we're talking about today. So go ahead. You're going to log on to this thing? He's going to drive this robot for you.
So you might have seen it earlier in the webinar, but for those of you who missed it, this is the Intouch software. Once you log on with your private account that the hospital or Carl Stores will provide you, you can log on to here and see all the different robots you have access to. A lot of these robots are just simulation robots that are up in a sim lab in California, and the robots up at the top right here are the ones here at the hospital. So you need to contact the technical support once you have your robot, once you have your account, to make sure that you have access to these specific robots. And they all have a serial number that go with it.
So there's a million robots up there, but you don't actually have access to most of them.
Oh.
Is every robot in the country listed there?
No, not at all. Of course not. So these are only the robots that my account, the DeBakey accounts that I'm using right now, have access to.
All right.
So, for example, I'm going to connect to this robot that's to the right of Dr. Lumsden, on your left, for those of you viewing. And to prevent audio feedback,
so can I just tell them that one of the problems having in here is you can get a lot of feedback. What you're seeing is Sam's screen, okay? He's controlling this with a mouse, okay? And so, again, run them through that interface.
Right, so this is the interface of the robot, so I can move, click around on this main camera.
You're going to see the guys who actually make this thing work. Tyree, show us Tyree. I want Tyree.
He's hiding. Oh, there he is.
Hello.
All right.
So, yeah, so as I click around and I can zoom in and create boxes, and it can zoom in pretty well, actually.
Yeah, zoom in.
So right now, just to let you know, I'm on the guest network on my personal computer. I'm doing this to show you that you can use any computer you want, any personal Windows computer that you have.
So show on the screen where all the questions have been coming up. And if you've got any more questions, send them in and we'll show you how we see them. They come up live basically on this giant screen we've got here. Yep, okay. There you go. Can I use remote system to see patients out of state? Aha. Well, you can certainly use it, whether you're in compliance legally. This kind of came up because there's a patient of mine that I'm going to see this afternoon is in Oklahoma. So, you know, I operated on him. He came down here. He's back in Oklahoma. I'm probably not going to bill him, but I'm certainly going to see him this afternoon. So yeah, there's no boundaries to where you can use it.
Anywhere in the world.
There are some medical boundaries because I don't have an Oklahoma license.
That's right.
I'd probably go to jail right after that. Yeah.
I won't out you, don't worry.
Yeah,
so
somebody will.
So yeah, so these are the controls. So I can switch between feeds. So right now we have an HDMI input, and that is the ultrasound that is connected.
Yeah, let me just see if I can walk over that.
And I can actually, on the computer, like I said, you can see two at the same time. On an iPhone or iPad, you'll only be able to see one. So I can simultaneously move around, see what Dr. Lumsden is doing. Oh, he's putting the gel on him.
Putting the gel on. So again, this is live. This is now connected straight into the robot. Let's see if I've got a pulse. Now you can see my radial artery.
Right there.
You can see the Hipaa Compliant. So again, this is one of the things we do for radial artery puncture. And so it's that simple. It's just you got to have devices that can be connected into the robot. But that's the way to do this.
Right, and now I can go full screen and see in more detail, and that's especially important when you're looking at live fluoro. And then another cool thing is if you, on any video feed, you have this thing called live cursor mode. So you can point to a specific part of that image that is relevant.
All right, so let's do that with so I'm already covered in jelly. Let's just do it again. You can point to my radial artery. Okay, that big round thing right in the middle. Can you point to it? Yep, so he's showing me radial artery, and then go to the little circles on either side. Those are my, right there, that's my Hipaa Compliant. Now this could be a device. So for example, this could be proximal markers, distal markers. This is where the flow divider is. That's kind of how we tend to use it.
Right, and let me just share an anecdote. So we have used this technology also in the colorectal side, where we hooked up the Visitor 1 to the Da Vinci robot, to where Dr. Eric Haas, who works in colorectal, could see the telestrations of that remote user in the Da Vinci console.
So that's another interesting use story. This was I guess it was a program he was running where there were supposed to be 4 surgeons coming in from Singapore to watch him do colon resection using an intuitive surgical robot. Well, of course, that got stopped. And so this was actually taken over. Was this our robot that you were using with the GI guys? Did we bill them for that, or did you take your
So we
robot?
actually used the Viewpoint, which is the demo. Yes,
Okay.
it belongs to
But
us.
what they did was they transmitted that to the surgeons, and so the course went ahead despite the fact that they couldn't be in the hospital. Hopefully they enjoyed it. The feedback sounds like it was really good.
Yeah, it turned out really well. And so that was actually the first use case for us. First time anyone in our company had done something like that using the Da Vinci robot alongside the Visitor 1.
Okay, we're going to wrap this up soon. So if there are any final questions, send them in.
And you can also take pictures remotely, record through here. Of course, we have built-in stored AV integration in the operating room, so we can record anytime we want and any video feed we want. But if the remote user also wants to record, they have that capability through the Intouch software.
Okay, Sam, that was great. Again, hopefully this has been of some value. I'm not into doing anything that's going to compromise patient safety. I really think this is the future, and I'm glad that you logged on. Contact us if you've got any questions with it, and I want to thank Sam really for being here to help demonstrate it. I don't want you to think that we depend upon him to do that. I could have run this actually because it's really pretty simple. Sometimes when you have somebody from the company doing it, they go, oh my gosh, it's complicated. It's not complicated to learn how to do this. So thanks again. Thanks to the team for being here.